program is going to work today is that we have 10 presentations. You're going to be given 3 to 5 minutes to give your presentation, and then we're going to take a few minutes to ask some questions. I'm going to have you on a timer, so once the timer goes off, that's the time we will conclude any questions. We're going to move on to the next abstract because we are on kind of a tight schedule. I will say if any of our judges have questions that are not able to be answered during that time period, that you guys can go outside after the President's Cup and chat for a little bit to answer any of those questions, okay? All right, so our first presentation is going to be a case study coming out of SUNY Plattsburgh. We have Liam. So Liam, why don't you get us started off?
So good afternoon, my name is Liam Rain. I'm a senior at Plattsburgh State University and I'm majoring in business and wellness leadership. Today I'm presenting a clinical case study of a right shoulder osteoid osteoma. So starting off with the history of the injury, a 19-year-old right-hand dominant male collegiate baseball player first complained of shoulder pain in his right shoulder in spring of 2020. After being initially evaluated by our athletic trainer, who was thought to be a possible superior labrum anterior posterior lesion or rotator cuff pathology. He was prescribed rehabilitation, range of motion exercises, ice and heat, ultrasound, and electric stim, all prescribed, but had little effect. He was also seeing a chiropractor and taking non-steroidal anti-inflammatory drugs. And since pain did not resolve with either of the aforementioned treatments, he was removed from play and referred to an orthopedic surgeon. During the orthopedic surgeon's evaluation, mild point tenderness with palpation of the proximal biceps tendon was noted throughout the anterior shoulder, especially along the posterior superior scapula. His shoulder would also pop with certain movements, and he experienced occasional ulcer sensation in his third right finger. Strength and range of motion were all within normal limits, with the exception of a slight deficit of internal rotation in the right shoulder, as seen. Here, he had 45 degrees of internal rotation in the left and only 15 degrees in the right. Special tests, the O'Brien test, impingement sign, and load and shift test all returned negative results. And because of that, the athlete was referred for an X-ray, CT scan, and an MRI. The X-ray didn't show any shoulder pathology, but the MRI showed a small amount of fluid tracking under the superior labrum and biceps anchor, along with a small cortically based focal lesion at the base of the coracoid process. Along with that, there was a substantial amount of edema throughout the coracoid and superior aspects of the bone. The CT scan showed a 0.88 by 0.8 centimeter lesion at the base of the coracoid process posteriorly. This can be seen over here. The MRI showed a small darker circle where the lesion was, and the CT scan is the fainter light circle just there. So initially, the issue was thought to be a possible slap tear, flat lesion, rotator cuff pathology, shoulder impingement, or a biceps tendonitis. But after the CT and the MRI, he was able to be finally diagnosed with an osteoid osteoma at the base of the coracoid process of the right shoulder. The treatment he received as a result was a CT-guided biopsy and a radiofrequency ablation of the right scapular osteoid osteoma. And this surgery was performed in April of 2021. After that, the athlete was able to return to play collegiate baseball with no restrictions in September of 2021. And what makes this case study so significant is that osteoid osteimas don't generally develop outside of long bones. So it was uncommon for this to develop in the scapula. And although this case itself is rare, just like cases that have obscure diagnoses aren't particularly that rare within our student athletes. So it's common for athletes to be misdiagnosed and as a result not receive the appropriate treatment. Now, carry some weight with me as well because I was one of these athletes. I played soccer at Plattsburgh. Unfortunately, I had to play through pain for the best part of a year because of a condition I had that wasn't diagnosed properly. That's why this case to me is so significant. And the opportunity for me to work with so many different departments, like the athletic training department, the fitness and wellness department, and the Champlain Valley Physicians Hospital, I got to work so close with the doctor who actually performed this surgery. So for that, for me, pursuing a career, wanting to pursue a career in sports medicine was just eye-opening, and it was great to be so close to this sort of thing and be a part of that. So with that, I thank you, and I open you up to any questions.
Let's stand by the podium so they can hear you. We're live streaming this also, and that's where.
Oh, that's where.
Okay, this is open for discussion. If anybody has any questions.
Yeah.
I was just wondering, is this a normal process for an athlete where they have access to an athletic trainer and then X-rays and MRI? I was just wondering how normal this is for an athlete to have, significant care part of their treatment.
So generally, for our athletes, we always have access to an athletic trainer. So first, him going to the athletic trainer, that's common. So like when I intern in the athletic training room, and we can just walk in whenever we want if we have a injury we might be dealing with, and we can get treatment for that. The chiropractor is less common. That's on his own time. He went and saw the chiropractor, but we have a team doctor that works out of Champlain Valley Physicians Hospital, because that's actually it's 2 minutes down the road, like literally. So with some injuries, with some athletes, they get referred to see that doctor because he'll come in weekly, bi-weekly sometimes to see specific injuries. We have a few ACL tears at the moment that he'll check up on them. And then generally any athletes with injuries that have lasted a longer period of time tend to see him, and sometimes it's a peace of mind thing. So because this athlete, he had no, his symptoms didn't resolve at all from any of the treatments that the athletic trainer was able to give him. That's why he was referred to that doctor. And then generally X-rays, MRI and CT scan, it's kind of up to the doctor. But X-rays for us, that's pretty common as well. We have a lot of X-ray imaging places around us that we get referred to when we have any issues like that. So generally, the MRI and CT scan, not as much, but the X-ray and the athletic trainer, access to that is pretty common.
Okay, I think we're out of time for this presentation. Thank you very much. If you have any questions, you can repeat them. I will ask if you're presenting, just try to stay close to the podium, because that's where our microphone is live streaming. Okay. And be sure to introduce yourself when you're up there, so we know who you are and where you come from.
How's everybody doing?
Good.
My name is Peter Calici. I'm a senior exercise science major from Manhattan College. I'm going to New York Medical College to pursue my doctorate of physical therapy in the summer of 22. My project is on the acute effects of eccentric quasi-isometric training versus static stretching on shoulder range of motion. Throughout the literature that we conducted, we know that 70% of Americans suffer from shoulder issues at least once in their lifetime. A traditional flexibility intervention would be static stretching, which is a constant hold of an end range position. We know that it produces a short-lived range of motion with no physiological adaptations that are sustainable. The other intervention we use is eccentric quasi-isometric training, or eccentric loading, or EQI. It involves using a submaximal load and isometric contraction when the muscle eccentrically lengthens through a full range of motion. In other words, the muscle is undergoing a stretch while resisting an external load. And through more literature that we conducted, we found that EQI provides an effective overload stimulus needed for tissue adaptation with low injury risk. The purpose of our study was to compare the acute shoulder flexion and range of motion changes from EQI versus static stretching, and our hypothesis asserted that a training session with EQI will be more effective in improving acute shoulder flexion and range of motion in college-age males. So in terms of our project design, we recruited 11 college-age males as our test subjects. Active shoulder flexion and range of motion of the non-dominant arm was assessed before the intervention and retested after the intervention. And for the pre and post measurements, we did before and afterwards, and the interventions, both static stretch and EQI, were counterbalanced, performed on non-consecutive days, and lasted for 40-second duration intervals. Now diving into the experimental setup, we can see up top, figure 2, that's the one in the middle, that's how we measure shoulder flexion. Your static stretch is your classic behind the neck stretch. I would demonstrate it if I wasn't wearing a suit, I would yell at the shovel. So figure 4 is the EQI technique. What does that look like? The test subject had in their hands, in a neutral grip, a dumbbell equaling 5% of the test subject's individual body weight. From there, they would eccentrically lengthen to a first sticking point in the overhead shoulder flexion arc. They would hold that isometrically for 30 seconds. After that 30 seconds, they take a full inhale, hold for 1 second, fully exhale, get all the air out. Gravity will eccentrically lengthen them to the second sticking point, and they would isometrically hold that second sticking point for an additional 10 seconds. We average all the data for the pre and post interventions, and you can see in figure 6, the change between pre and post for static stretching was about 3 degrees, while the change between EQI, pre and post, was 6.5 degrees. That is a twofold greater degree of change for EQI and static stretching in improving acute shoulder flexion range of motion in college-aged males. Diving into the results and conclusions, significant differences were found between the gain scores of EQI and static stretching. We had a p-value of 0.011, which indicates that we were 98.9% confident that EQI would improve shoulder flexion range of motion in college-aged males greater than static stretching. And we also found a Cohen's d, which is the effect size of 0.931, which basically means that the gain score for the EQI and the gain score for the static stretch differ by a standard deviation of 0.931. That's almost one whole standard deviation. Now, why does this matter? Strengthening muscles and gaining range of motion simultaneously can theoretically accelerate recovery time, but more resilient muscle tissue and produce more significant range of motion changes. In physical therapy, we shoot for the minimum adaptation that provides the maximum output. It's all about efficiency. And we know that the homeostatic disruption through overload can cause those physiological and adaptive processes needed to elicit improvement in muscle size and force production. And lastly, our research is the first outreach of EQI in the upper extremity, whose results can hopefully be replicated in the future. Thank you. I look forward for any questions you may have for me.
How long after the intervention did you retest range of motion?
So we did the intervention. Both interventions lasted for 40 seconds, and immediately after we retested the intervention, we tested the same. They're lying in the supine hook line position, as you can see in figure 2. We tested them, then we had the intervention, and then we retested them directly after. And the interventions were counterbalanced, so there was a day where they did EQI, they got a break in between, and then a day where they did static stretching. And that order was flip-flop for every single individual, that subject. Yeah, I'm here. Is that right? I'm Rico.
Great presentation, thank you. I was just wondering, why did you choose to only use men for example?
So it was interesting. In the literature that we found, the first 2 studies that we were referencing, Nelson and Vandy, both 2004 and 2006, did eccentric training on high school males. And what we wanted to do, we found also in the literature that males had a tendency to have a greater upper body mobility restriction, upper extremity tightness than females did. We wanted to keep the sample size homogeneous, as opposed to going back and forth. And it was a convenient, accessibility of convenience. When we were in college, it was easier for us to get males in that sense. And we wanted to keep consistency throughout the 3 studies, the 2004 study, 2006 study, and our study. Hopefully other people can branch out into different sexes after this study, because we want to go upper and lower extremity to be consistent, and then you can branch out from there.
No further questions. Thank you very much. Good job.
Something I think is also very helpful, you did a great job of, is when you're talking about a figure, please reference the figure number so our audience that's doing the virtual stream will know what you're talking about. And again, please try to stay as close to the podium as possible. If you do need to come direct to something, you can just kind of go, but make sure you return so we can, everybody who's tuning in at home can hear you.
Good afternoon, everybody. My name is Nick Dvorak. I'm a senior undergraduate student at SUNY Plattsburgh in the Fitness Wellness Leadership Program. I'm an ACSM certified personal trainer, and this is my first chapter conference, so I'm really honored to be here to present in front of you all. In general, the overhead athlete is susceptible to shoulder pathology. If conservative management fails to ease symptoms, shoulder arthroscopy is recommended. Today, I will present the efficacy of two arthroscopic methods in terms of pain and return to play. We collected data from 56 professional volleyball athletes who were either suffering from rotator cuff or glenoid labral lesion injuries, who all had subscapular nerve entrapment. Now, subscapular nerve entrapment is due to the forceful eccentric contraction of the infraspinatus muscle, which causes the subscapular nerve to become compressed within the subscapular notch. Now, this is incredibly painful for the athlete, limits their range of motion, and ultimately could hinder their future performance and return to play. We divided these participants into two groups. Group 1 contained 35 individuals who chose to undergo shoulder arthroscopy combined with subscapular nerve release, while Group 2 were the remaining 21 individuals who only chose to undergo shoulder arthroscopy without ACSM release. In order to collect pain data, we used two instruments, UCLA and constant scores. In terms of UCLA scores, both groups improved, however, Group 1 improved more than Group 2. In terms of constant scores, both groups also improved, however, Group 1 improved more than Group 2. Additionally, follow-up evaluations 3 to 5 years post-surgery revealed that there was a 97% return to play in Group 1 versus an 84% return to play in Group 2. These results indicate that shoulder arthroscopy combined with subscapular nerve release is the superior arthroscopic method. Now, this research is significant in two ways. One, from the perspective of an athlete, the other from the perspective of a practitioner. From an athlete's point of view, this is incredibly useful for them now that they know that this procedure will ultimately lead them back to a better chance to get back into play, reduce their pain. As an athlete, you don't want to be paying your top sport, especially at this level, in pain. You want to get back into play as soon as possible. From a practitioner's standpoint, they now know that this is an effective arthroscopic procedure that yields superior outcomes. I will not forget to underline the innovation of the study. The arthroscopic method alone is very innovative, as well as this is an internationally collaborated research within 2 departments at my university, 2 hospitals in Greece, and the med school in Athens. You all know how it is to gain access to this many elite level athletes, which leads to my research design. In terms of my research design, this longitudinal study where we managed to control many extraneous variables, ensuring we had the same pathology, the same surgeon, and the same level of athlete, we are confident that the difference in score is explained as an innovative arthroscopic method. These are actual pictures of the operating room in Greece, showing the subscapular decompression of one of the participants who chose to undergo the surgery in Group 1. I just want to thank you all for allowing me to present in front of you today. Take any of your questions at this time.
Abstract is open for discussion.
Great presentation, thank you. I was just wondering, I'm not familiar with the UCLA shoulder score. Can you explain what that means?
Absolutely. So UCLA and constant scores, they're both scored measurement systems to measure pain. And the UCLA score is actually constructed of a series of different tiered systems, and they're point systems. So the athlete would be asked a series of questions. How is your shoulder flexibility? And now being ranked on a scale of 1 to 10. And these points are combined and given an overall score. So that's what is used to measure the pain value.
You said that your study design allowed you the ability to make some determination of effectiveness. But wouldn't a randomized control trial be a real way to search out causality in this, because this is a longitudinal study. There's, in any given study, there's some variability, there's some things that, maybe are not controllable. What do you think about, what's the next step for this? Like, is a randomized control trial in your mind the next way to go, or is this sufficient evidence in your mind?
In my opinion, I think that this is sufficient evidence to support that this procedure not only works, but it is effective in both standpoints from the athlete and the practitioner. I think that the 97% return to play is way more significant than the 84% return to play. And ultimately, the athletes do want to get back into play as soon as possible. And for them to regain that full range of motion and having this many, the success rate being so high, I think is sufficient evidence to support.
All right. Well,
Thank you very much. Okay, we got Daria next. Yes, I'm here. So you're right there? Okay. And everybody, we're doing great on time right now. The pace is fine, so don't feel, there's no need to be rushed. I think that we're doing great on the time. There you go. Is it advancing the slide?
No, it's starting at the beginning. I'm not, do you have like a time thing on? No. Oh, okay.
Okay, in the interest of time, why don't we just keep it like that? I think we can see it okay. Did you want to slide that, over, make that one on the left, that tile a little bit lower?
Are you talking about the Zoom? Oh, no.
Yeah, just slide that slide
Oh, yeah,
over on the left where you have the panel, all right.
Is it
That's
better?
good, I mean, we can see it.
Okay.
Okay.
All right, well, hello everyone. I'm Daria Mustavi. I'm a doctoral student at Teachers College, Columbia University. And this is, let me show you the title first.
Yeah, please stay close to the podium so we can hear you, so that everybody can hear you.
Yes. So I'm presenting my work today, which is a collaboration between Teachers College and Mayo Clinic. And it's about the effect of dietary omega-3 fatty acids on the lipoprotein profiles in healthy older adults. So we know that LDL is associated with cardiovascular risk factors, and also we know that HDL, on the other hand, is has a negative relationship with cardiovascular diseases. We also know that omega-3 fatty acid is known to be cardioprotective through different mechanisms, such as lowering inflammation and also lowering triglycerides. So this effect of omega-3 fatty acid has been examined in different populations with different diseases such as diabetes, cancer, and cardiovascular diseases. But in this study, we aim to understand the biological effect of omega-3 fatty acid in healthy older adults. Sorry, I'm a bit stressed, so that's why. Thank you. So to do this, we recruited 30 young individuals who did not receive any intervention. And also we recruited 44 older individuals who were randomly assigned in placebo and treatment groups. And after the baseline measurements, they started a 6-month placebo or omega-3 intervention. The outcome measurements were taken pre and post intervention. And we used NMR, nuclear magnetic resonance, to analyze the to profile the blood samples and also to do the lipoprotein subclass analysis. And for the statistical analysis, we used a 2-way mixed ANOVA for repeated measures, and all the statistical analysis were done in RStudio. So if we look at table 1, you see that the supplement actually did not significantly change the triglyceride and cholesterol level, but it significantly lowered the ApoA2 concentration. But the subclass analysis actually showed us, if you look at figure 2, that the supplement significantly decreased the, let me enlarge this, significantly decreased the triglyceride, cholesterol, phospholipid, and ApoB concentration in the larger LDL particles. And these concentrations were increased in the smaller and denser particles. On the other hand, we see in figure 1 that cholesterol, phospholipids, and ApoA1 and ApoA2 concentrations were significantly increased in the larger HDL particles, but they were significantly decreased in the smaller HDL particles. So overall, this study is showing that despite the increase in the smaller LDL particles, which is associated with higher risk of cardiovascular diseases, it seems like omega-3 supplementation actually can shift the HDL composition and concentration toward a cardioprotective profile in healthy older adults. So this study basically suggests a potential beneficial effect of omega-3 supplementation, which should be considered knowing the cost and ecological effect of widespread use of this supplement. Thank you.
Okay, it's up for discussion. Anybody have any questions?
So the omega-3s were administered as part of a supplement. Was there any control over the people's normal diet, how much omega-3s they were eating?
Yes, they were receiving basically packages for their nutrition throughout the experiment. So they were like coming to the hospital and receiving their food every, I'm not sure how often, but they were coming to the hospital.
Were all these older adults, were they cognitively considered normal? Like, were any of them on the, did they have any incidents of Alzheimer's, dementia? Were they all considered cognitively healthy? Because I'm curious to know some of these ApoE subparticles being highly influenced in the pathology of Alzheimer's. Do you know anything about
Yeah, that's a very interesting question. I do not think that we had such a thing in our criteria. They were screened for their like lipoprotein and blood pressure, those kind of measurements.
Okay, great, thank you.
Thank you.
Okay, we got wheels up next. Yeah, please get started. And remember, close to the podium, so our audience at home can hear you.
Hello, everybody. My name is Wheels Pellin. I'm a senior at SUNY Plattsburgh, and I major in expeditionary studies. Now, I know what everybody is thinking. What incarnation is expeditionary studies? Well, I'll go ahead and explain. You see, my research project was based around expeditionary studies. Expeditionary studies is all about having an outdoor curriculum, an adventure sport schedule throughout the semester, in which we do rock climbing, whitewater paddling, backcountry skiing, anything outdoor and exciting, you name it. That's us. For my research project, I wanted to study how freshmen expeditionary studies deal with how their mental health and mental toughness is affected by an outdoor curriculum. When it comes to mental toughness, remember, it is heightened with risk. And if there's one thing about expeditionary studies, there's risk. Because hanging out on the side of a wall is really scary and really risky. So we wanted to measure this, and we wanted to use a different kind of group. We wanted to see, like, okay, what can we compare it to? That's when we picked the fitness and wellness department to measure at the control group. You see, why did we pick them instead of, say, the business majors. Well, that's fine. That's because they do a similar course to us. They're outside, they're active, they're running around, they're not in a classroom, but they're also not going down a river of whitewater conditions. So they are close, but not exactly the same. So in my study, we used 28 freshmen out of the fitness and wellness students to measure mental health, mental toughness. We used 14 freshmen in the expeditionary studies program, and also we used upper level EHP students to measure how their mental health and mental toughness changed throughout the year. We used our method of using a one-way analytical variety or ANOVA collection system, implemented it twice throughout the semester, one in the first week and one in the fourth week. We're planning to do 2 more collections later in the semester. The results, well, a little surprising. It showed that in figure 1, you can actually see it, that the fitness and wellness students had a higher sense of mental health than the first year expeditionary studies students. But continuing with it, it showed in the second figure that comparing mental toughness between first year expeditionary studies students and later years, that the later years started with low mental toughness and then it gradually increased as the years go on. But with the first year EXP students, they started with high mental toughness and ended with that high mental toughness. You can see on our third graph, you can see the correlation between the fitness and wellness, mental health, mental toughness compared to the EXP students. To be completely honest, the correlation is not huge, because this is a preliminary result. We still have much more to do, much more questions to discover, and things to understand. I'm here in conclusion, we took the advice of Keaton Scott, a past EXP student, actually presented at this very conference of her findings. The things that we decided to change was having a control group, the fitness and wellness students, while also having more variety with other students, higher up EXP students rather than just the freshmen. Again, we're going to be doing other collections throughout the semester, and hopefully we'll have better results and more clear results when I present in Texas. How is this significant? How is this innovative? Huh. I think the real question is, how is it not? I mean, have you seen anything like this before? This is absolutely amazing. The coaches, administrators, practitioners, we can use exercise as medicine. And if we can continue to figure this out, imagine what we can do in the future. Imagine going to the hospital and seeing the doctor. You're sad, you're depressed. They don't give you pills to swallow every day. They give you, hey, go run outside for 10 minutes. Go rock climb. I mean, the possibilities are endless, people. Now, if anyone has any questions besides why my name is Wheels, I'm ready to answer. Thank you so much.
Okay, that track is up for discussion.
Thanks for that, Will, that was fun.
I tried.
My question is, between the first and the fourth week, what kinds of outdoor activities did people do? Like, was there set activities?
Yes, so what we did was we went ski kayaking in Maine for 7 days. That was fun. We went on a canoe trip, and while also doing day trips with rock climbing, whitewater paddling in harsh rivers and whatnot. So we had a nice collection of day activities, while also like 7-day trips, 3-day trips, et cetera, et cetera. So we had a nice variety of things, again, but not just rock climbing, but like also paddling, and we get to ski right now, but you know. Any other questions?
Yeah, something that happens, I think, a lot in research where your scales are somewhat finite, is that you have the floor effect and a ceiling effect, meaning that somebody comes in at a low level, they got no place to go but up.
Right.
So if you want to get to the bottom of this, is your intervention really effective? How do you sort that out? Because if you always have people with low levels to start off with, they're always going to increase.
Right.
It even happens, and that's the reason why your high achieving group, high mental toughness or whatever it might be, they're not going to improve because they have nowhere else to go.
Right.
Is there a new scale that needs to be derived? Or can you only be so tough comparatively?
I think it's one of the things where you have to watch it and continue throughout the year. As you go through expeditionary studies, the trips get hard. You want a longer trip, much colder, rainier, more miserable trips. So measuring, if we had a way to measure it throughout their all years of college, I think we'd see some really interesting results. I think go up and down. So I know there's times when people are like, I love this, and there's other times I'm like, I hate this. So we'd have to measure that throughout the years.
Okay. All right. Thanks a lot.
No problem, guys.
Hi, everybody. I'm gonna do my best to follow up that energy that Wheels just brought through. So my name is Zach. I'm a senior exercise science student, psychology minor at Manhattan College up there in the Bronx. And Wheels came from Plattsburgh, and all the other Plattsburgh, they took a plane. I just took a walk and a train downtown. So I'm happy to be here, and thank you for staying by the mic so you guys can remote can hear me. So similar to Wheels' study, I looked at the perceived effectiveness of strength and conditioning protocols on mental toughness in Division I women's basketball players. Now, before I get started, I'd like to ask you all, what does mental toughness mean to you? What does resiliency mean to you? Now, mental toughness, as defined in the literature, is a personal capacity to produce consistently high levels of subjective and objective performance despite everyday challenges and stressors, as well as significant adversities. Now, in the literature, in a large body of literature that is, there has been consistent studies with male participants, yet a lack of studies in female participants. Now, because of socioeconomic and other different factors that play along with it, we often associate mental toughness and resiliency and look at that in the male population, but often seem to neglect that in the female population. So by using a quasi-experimental design, we focused on specifically looking at just female Division I women's basketball players. And the purpose of the study was to explore the perceived effectiveness of mental toughness between a pre-intervention and a post-intervention with their strength and conditioning protocol. Now, to examine possible differences in the perceptions between strength and conditioning coaches and the players themselves were also analyzed. Now, why is this important? I feel like harmonious perceptions in mental toughness are important for not only defining it, but also measuring it and how it plays out in performance. So with this quasi-experimental design, we used a certified strength and conditioning specialist at Manhattan College and the Mental Toughness Index, also known as the MTI, that was created and established in previous literature and brought to light through Dr. Stamatis up in Plattsburgh. With the MTI, we distributed this over the course of their six-week training protocol 5 different times and saw a significant increase in mental toughness levels before the intervention and post-intervention levels. So as we can see in figure 2, there is a minimal difference or less than significant difference in the perception of the teammate and the self-perception. So in this study, we asked the female basketball players to self-perceive their own mental toughness. We asked their teammates to perceive their own mental toughness, the teammates to perceive of their other teammate, and the coach as well to rate rate them on their perceived mental toughness themselves. So with the trivariate scores, we noticed an extreme significant difference in the levels of coach perception of mental toughness of the athletes and the athletes' perception themselves. Now, as you can tell, in figure 2, there's the 2 lines that are closer to each other at the top. That represents a more harmonious perception of mental toughness between the athlete and the teammate themselves, therefore leading to not a significant difference. Now, the conclusions of the study are very important for multiple reasons. Number 1, to destigmatize mental health, not just in the male population, but in the female population as well. By incorporating mental toughness, resilience, strength-based training, and educational workshops within not only athletics, but in other areas of sport and performance, certified mental practitioner coaches and other strength conditioning coaches can collab and work together in order to improve the mental health and increase mental toughness of all performers. Now, for future direction and limitations, to examine possible different physical outcomes associated with the intervention itself. So increased stability, endurance, flexibility, things like this could be looked at in future research as a way to define and enhance the MTI as a tool. Now, before the presentation, I asked you all to think about what mental toughness and resiliency means to you. And I hope that through these results, it shows that your definition might be different than the definition of the person sitting next to you. And by understanding that those definitions can be different, we can lean towards better research with better resources to more comprehensively define what mental toughness means to us, what it means to others, and how we can incorporate that for better performance. Thank you. What questions do you have for me? Yes.
I think you already said my part, but.
Okay.
There we go. So this one in the last video, you mentioned this perceived mental toughness scale and it being validated. Can you just elaborate on what the scale is, how many questions it is, what type of questions?
Of course.
What does it look like?
Yes, so if, I could actually, maybe not, but I was gonna have to try to zoom in on this mental, if the graph, the actual scale itself is in the bottom center of the page. There is 8 questions on the scale, all ranging in different, different questions related to different components of mental toughness, like resiliency and autonomy and success mindset and resiliency in terms of adaptability and things like that. And race on a Likert scale, according to what we learned earlier in the conference, the Likert scale, rating on a scale of 1 to 7. And so the lowest possible score would be an 8 and the highest possible score would be 56. Yes?
I'm interested by the difference between athletes' perceived mental toughness and the coach. Can you speak to, was the coach a man or a woman? And sorry, one second, but also, is there also that difference if you tested this in male basketball players?
So I'll answer the second part of that question first. Personally, no, we have not tested in male basketball players. Now, there have been some studies done with male basketball players, but those results were kind of a little bit inconclusive because of the mental toughness stigma with males. They rated themselves higher, and the perception between the males and the coaches were more harmonious, and the perception because of the male being a coach with the male athletes. Now, that goes into the first part of your question, where was the coach a male or a female? And the coach was a male. So the strength conditioning coach being a male, assessing female mental toughness, I think there was definitely some barriers there. And I'm not exactly sure if that was a direct correlation in the reduction of the scores, but it's something to look at for future studies, that a male strength conditioning coach rating female participants or athletes, I think that's something to look at. So yes, the coach was male rating female. Yep. Any other questions?
Yeah, I have, and I think it's more general about the field and the study of mental toughness. I think what makes it interesting is it also makes it difficult for me to understand the assessment. You said that everybody has their own definition, everybody has their own ideas. And that makes it's going to make it innately difficult to measure on a scale. Do you have any plans? Is that 8 questions sufficient, or?
I don't think so. So I don't think that the scale itself is sufficient. Now, by collaborating on future research and more comprehensively defining mental toughness on a large scale for different populations, I feel like there is more room for the field to grow. Sports psychology is a fairly new field, a very niche field, especially within exercise physiology and how they both correspond with one another. So there definitely still needs to be some work done with that.
Great. All right, thank you.
Yeah, and if there's any other questions on the business cards up here, you can go ahead and ask them next meeting. Thank you.
Sure.
Hi, my name is Madison Letcher. I'm a senior continuing classroom, majoring in fitness and wellness and minoring in nutrition as well as personal training. And I'm also a research assistant to Dr. Andreas Dematis. I've spent a lot of time this past semester attending men's soccer practices and gathering information using a GPS sensor. So I'll be showing you the results of 5 different metrics, including sprint count, sprint speed, GPS loading, total distance, and explosive count. This project came about from our men's head soccer coach, Chris Taylor, who wanted to know how the 2020 season cancellation affected his team. In order to do this, we took all of the players who were on the team in both 2019 and 2021, looked at equal time periods, starting during preseason mid-August and ending mid-October. We were able to use the Titan ONE+ GPS sensor to collect and compare all of our data from all the practices and games of both years. Our results showed that according to all of our metrics, except for one, sprint count, that our men's soccer team is actually doing more than they were compared to pre-COVID. Now, you can see that the solid black line is 2019, and then the dashed red line is 2021. Now, out of our other 4 metrics, total distance and sprint speed happen to be statistically significant when looking at P and D values. This information is significant in 2 ways. In theory, because we've never experienced a complete shutdown of a sports season in our lifetime, so this is a very unique opportunity to investigate the effects that it had on our team. Also in practice, because we can take all this information, bring it back to our coaches and help them develop a deeper understanding for what their team can handle and why. In fact, our men's soccer coach, Chris Taylor, is currently using this information to see how his team doing more relates to increased success in games or if it's increasing injuries throughout the season. Our research does not end here. Our next plan is to present a Texas ACSM where we are going to present more information on practices versus games per position. And the ultimate goal of this is to come up with specialized practices based on game data. And it's also important to note that our team is a Division III team, and Division III teams happen to make up most of the participants of the NCAA, with soccer being the second most popular sport. This information can be beneficial and applicable to a majority of people. This is also innovative in two ways, because this was an inter-institutional collaboration with Baylor University, and also because according to ACSM, wearable technology happens to be the #2 fitness trend for 2021. Thank you for your time. I'm looking forward to your questions.
Question, I think I might have missed it. What do you mean by doing more? You said that post-COVID, they're doing more. What does that mean exactly?
So specifically in the 5 metrics that we looked at, except for sprint count, they are doing sprints faster, their GPS load is faster, their explosive count is faster, and they're running more total distance than they were before.
Okay. And is that, well, I know somebody else is going to take this question, so I'll let somebody else. You got it?
I think I have a same question. Is this during games or practice?
This is all together. We are averaging everything together.
So how long do they wear the accelerometers for?
They wear them from the beginning of practice to the end. So it's like the entire time, during warm-ups, during their drills, cool down, everything.
And also during games?
Yes.
Yeah. So if they have, but they didn't have games last year?
No, that season was canceled.
Okay, so I guess the question is, inevitably, if they didn't have games in the pre-COVID time period, the fact that they're playing games and you're measuring that, is that explaining the difference? Just the fact that there's games now, or is this data?
We had data from 2019, from before the cancellation.
Gotcha. Okay.
Yeah, that entire season.
Okay, that makes sense. That makes sense. I guess I'm very curious to know, this is very interesting. Do you think that there's some, like, how do you explain it? Do you think they're trying to make up for lost time, maybe? Like, what would be your speculation on why this is occurring?
I think it may be because since the season was canceled and there wasn't as much pressure and they were really just training, they just got, like, their staffs up and everyone just kept conditioning, and they came back wanting to win, wanting to have a good season after the cancellation, and I think that might have a lot to do with it.
Okay. Well, that's very interesting. Thank you. All right, David, take it away. All right.
Hi everyone, my name is David Ewer. I am a graduate student at Teachers College, Columbia University, as well as a research assistant at Columbia University Medical Center in the Department of Rehabilitation and Regenerative Medicine. So my project is on the exercise intolerance reflects impaired mitochondrial function in spinal muscular atrophy. So a little bit of background first about spinal muscular atrophy, SMA. This is a rare genetically linked neuromuscular disorder characterized by muscle weakness and impaired motor function. This is caused by a decreased production in the protein known as survival motor neuron protein, SMN1. Now, there are a couple different phenotypes. The phenotype that this project is about is type 3. There's type 1, type 2, type 3, and type 4, determined by the amount of SMN protein available in the body. Now, SMN protein is ubiquitously produced throughout the body, but specifically affects muscle cells and motor neuron function. So of course, muscle cells are important because we have mitochondrial respiration responsible for producing ATP via the process of oxidative phosphorylation. Now, in SMA, skeletal muscle has been seen to exhibit decreased mitochondrial biogenesis as well as decreased, or rather, mitochondrial depletion. So, previous studies have shown that in specifically type 3 SMA, children and adults show a blunted response to exercise training. So this suggests an impaired oxidative phosphorylation and decreased exercise capacity, which can result in exercise intolerance. Now, exercise intolerance I'm defining here based on a couple different variables marked by inefficient VO2 oxygen uptake, as well as a disproportional ventilation or VE increase with exercise. So this has been assessed in mitochondrial disease specifically, as well as a few other neuromuscular disorders, but not specifically in SMA. So again, the purpose of this project to look at these variables specifically in SMA. So we're looking at VO2, oxygen efficiency uptake slope, the OUES, and the ventilatory equivalent for oxygen, VE, VO2. So for our study, we had 18 SMA participants and 16 healthy controls visit our lab and complete a maximal cardiopulmonary exercise test, the CPET. So we determined their peak VO2, their oxygen efficiency uptake slope, and their VE VO2. Some brief background about the OUES. So this is determined by the equation VO2 is equal to A times the log of VE plus B. Significant component about this is using a log transformation on VE to turn the normally curvilinear relationship of VE and VO2 into more of a linear relationship. So you get the slope, you get the OUES. So we did a non-parametric test and then Whitney U test to determine group differences between our cohorts, and all results processed through SPSS. Now, if you look at table 1, we have results for our SMA and our healthy control group. For age, height, weight, and sex, you can see no significant differences between groups. We also have our disease duration and age of onset for SMA. Now, if you take a look at figure 1, this represents our VO2. You can see a significant difference between peak VO2 in our SMA and our healthy control groups. In figure 2, we have the OUES, again, significantly higher increase or significantly higher OUES in healthy control compared to SMA. And then figure 3, significantly higher ventilatory equivalent, the VE VO2 in our SMA group. Now, spend a couple more seconds on figure 4, so stay with me, be a little confusing at first. The blue line, the steeper line, represents one representative from our healthy control group. And in green, the slightly flatter line represents one representative from our SMA group. So those individual dots represent specific points in their exercise test. So you notice that there are more blue dots than green dots. We had our healthy control participants, for the most part, undergo longer CPETs. They were able to handle more exercise compared to our SMA participants who, in terms of test length, went a little bit shorter. So they have a little bit less data points. But you can see in blue, the steeper group, the healthy control, much steeper OUES compared to our SMA group. Also want to note, not specifically mentioned here, but very important and often talked about in this kind of area is the ventilatory threshold. In SMA, there was no observed ventilatory threshold, so nothing to report here as far as a comparison. So what do these results exactly mean? So we see that there is a severe attenuation in VO2 as well as the OUES in our healthy control group and SMA, and this mismatched and this hyperventilation response in our SMA group as shown in figure 3 here. And again, I'll reference figure 4 here. There, the flattened, the less steep OUES slope in our SMA group. So these attenuated VO2 responses and OUES responses, along with this exaggerated hyperventilation response, are consistent with known findings in mitochondrial dysfunction in SMA. And these results do support the concept that exercise intolerance may be a result of impaired respiratory chain function due to alterations in mitochondria in SMA. I think going forward, this further proves that CPET is a valuable method to assess exercise capacity in spinal muscular atrophy, and does reinforce the belief that mitochondrial dysfunction is a significant component of impaired aerobic activity in this cohort. So this could suggest possible alternative training methods for this group. Because again, for some background information, there was a study done looking at aerobic training, 5 days a week, 30 minutes a day, and this is where we saw those blunted aerobic capacity responses. Another key component that this study could lend credence to is the concept that mitochondria could be a successful target as far as drug therapies. So currently there are a couple different drugs out there, one for SMN repletion and a couple gene therapies, but nothing specifically that does target the mitochondria in SMA yet. And that's it. Have you taken any questions?
Anybody have any questions? I know right off the bat, I look at the title of your poster and I'm still looking for some measurement of mitochondrial function. And I think it's, from what I'm understanding, you're saying that the OUEF is being explained by impaired mitochondrial function at some level.
We can't directly say anything about mitochondrial function with this, so these variables support the idea that mitochondrial function is impaired. If I can go back quickly and just reference the Fick equation, VO2 equals cardiac output times AVO2 difference, break down what cardiac output is composed of, stroke volume times heart rate. If we have no real reasons to see that stroke volume or heart is significantly impaired in this group, we know that changes in VO2 we not know. We can expect that change in VO2 are coming from that AVO2 difference. So again, this supports the idea that it's not a cardiovascular capacity to deliver oxygen to the working tissue. There's more than likely an oxygen uptake issue as opposed to delivery.
So you have near-infrared spectroscopy at your institution?
We do. There's been a previous study looking at NIRS from our group.
So you can measure mitochondrial function using near-infrared. You can do kind of a surrogate.
Another surrogate, exactly.
Analysis, I guess. I think that's the biggest limitation. I think it's lovely data. It's just that bridging that gap. Because right now, I'm still, I think you're gonna have to show a level of evidence. It's just, if you have mitochondrial function on your slide, I need to know, so like looking at, and maybe a biopsy, getting mitochondrial content. Is it function, or did they have reduced mitochondrial content? I think those are two things that you're gonna have to sort out, but it's definitely a very important question and study, and I'm really fascinated by this SMA group. Any other questions? Okay, thanks very much. Okay, I just want to let everybody know that we're still doing really well on time, so nobody needs to feel rushed. We've got plenty of time to finish our presentations. We're on schedule.
All right, so good afternoon, everybody. My name is Dylan Riley. I am a senior at SUNY Plattsburgh, and I am currently in the major of fitness and wellness. I'm also looking to forward my education in a master's program, specifically athletic training. So this case study was very significant to me because I was able to work with the athletic trainers at SUNY Plattsburgh as well as doctors on an international level from Greece. So what am I going to be presenting for you in this research study today? It is hip arthroscopy in elite athletes. So why is hip arthroscopic surgery important? It is important because it is a very minimally invasive procedure. And basically, as you can see in the bottom right corner of my presentation, you go in with a scope as well as the surgical tools that are needed, which helps because previously you would have to go into the site, the injured site, have an open surgery, which would prolong the recovery period as well as make the recovery period more intense. Whereas now we are able to get our athletes back to full potential with this alleviated pain in 12 weeks, which leads me to the purpose of my research study, which is to examine whether the hip arthroscopic surgery is beneficial in terms of alleviating pain as well as returning these active elite athletes to play. So as you can see under methods, we had 35 elite athletes, which in itself is extremely rare to have this sample size in elite athletes with the same specific injuries and symptoms. As you can see here, they had no prior injuries causing these hip symptoms. They also had no hip dysplasia, and they also all went through a 3-month conservative therapy program with medication, which also did not alleviate the pain. After they went through these three trials, they ended up all agreeing to undergo hip arthroscopic surgery, and they were all out of the 35 elite athletes, they were diagnosed with either labral detachment, FAI, which is femoral acetabulum impingement, or cartilage defects. So part of the research study was obviously to see if we were able to alleviate the pain. So how we scale that before and after the surgery. We did that by doing the MHHS score, which is the modified Harris HIP score. So that is scaled out of 1 to 100. The higher the score, the more you were able to do daily functional activities without pain. The lower the score, the less functionality you have, and the more pain you have. So as you can see, we took it pre-surgery and post-surgery. Pre-surgery, the number is lower, and then post-surgery, 12 weeks after, was higher, which shows the significance of hip arthroscopic surgery and how it was able to improve and benefit these athletes. In the pie chart here, it is broken down into 3 groups. 83% were able to return pain-free to their elite sport, as well as having alleviated pain. 8.5% returned to their sport after going through a rehabilitation program because they ended up developing tendonitis, but they were able to return with alleviated pain and full potential after 15 to 18 weeks. And then the last 8.5% ended up going through developing heterotopic ossification. But the important part about these 3, that they're broken down with these 3 ways, is that none of these 35 elite athletes ended up having to go back and being reoperated on, which is extremely significant because there's 35 elite athletes and there was not one that actually had these symptoms again and went back to have surgery. So in conclusion, the results of my research study was that it indicated that hip arthroscopic surgery has been successful in alleviating pain, as well as getting these elite athletes back to play in a respectable amount of time. It is also significant because if you are an elite athlete, obviously if you're having these issues in your hip, it's going to affect your everyday lives, especially now your job if you're an elite athlete, to an extreme extent. So this is a great way for elite athletes to be able to return to play in an effective manner. It's also very innovative because surgeons are now able to see these instances with these elite athletes and have a way for them to continuously grow in this field and continuously help athletes with injuries arthroscopically and helping them return to play quicker than usually like they were before. And that is my research study. If you have any questions, please let me know.
I'm just interested in the sample itself. What was the inclusion criteria? How did you find this sample since they all had to go through this conservative therapy first? What were the signs and symptoms that they had to complain of to be included?
So this sample size that we have with these 35 elite athletes, the doctor that was involved with the surgery, he actually had direct access to all these athletes because they were a part of volleyball and basketball in Greece. So he had direct access to them, which then is very important because they were also allowed to have the same surgeon, the same physiotherapist post-surgery, and they all, like I said, came in with these same symptoms. So they kept the control group very condensed, and there wasn't that many extenuating circumstances. So it really did show the significance of how hip arthroscopic surgery could be successful.
I was just wondering, in your background research, are there any long-term consequences? So if everybody went back to play, what about 10 years later or 20 years later?
So as of right now, we didn't have any results on that, but the fact that they all went through the same surgery and they all didn't have to return, they didn't have to go and get reoperated on again, shows again a significance in how well this surgery is performed and the ability that they are allowed to return to play post-surgery.
And I was wondering, in the athletes who developed tendonitis, was there anything similar about those 3? Did they start too soon, or go too hard?
It was basically one of the side effects of the surgery itself. That, like with the ossification too, it was just something that ended up happening based off how their bodies healed in different time frames. But they were all able to return to play effectively after a certain period of rehabilitation.
Tell me a little bit of what it's like to have to coordinate these research findings with somebody overseas. I see that occurring a lot in the Plattsburgh students, and I always think it's an accomplishment to do this. But give us a little bit of insight of what that's like.
So it's a very extensive process. We're very lucky to have Andreas Tomatis as our teacher and our mentor. He's from Greece. He has a lot of connections in Greece. So being able to have that type of international aspect to research studies like this and having connections around the world, it really does help us be able to get these rare circumstances to be able to present for you guys because, like I said, 35 elite athletes from somewhere around the world internationally is pretty rare.
So, I did that to lead you into this. Is there any concern about the technology, the approach, the athlete itself being from Greece compared to somebody in the United States? Are those results completely applicable here? Because we approach things a much different way in the States than we do overseas. What are your thoughts on that?
I definitely think there could be a certain aspect where sports here and sports in Greece could show up different variables, but at the same time, they're the same sports. Looking at volleyball, basketball, even soccer with the side collisions that they get a lot from hip contact. So looking at those three sports, they're pretty relevant to either here or in Greece. So I think that theoretically, depending on how the certain sports are played, there could be differences, but overall, I think they're pretty consistent.
Okay. All right. Thank you very much.
Absolutely.
All right. So our final presentation is going to be done remotely. Let me just make sure that we have. And then we'll be sharing your screen. If not, you'll be.
Janelle, can you hear us?
Yes, it's not letting me share my screen.
That's okay. We can put your presentation up, and if you're capable of seeing it, if you have your slide up, you can start as soon as I get this. Maybe slideshow. Okay, your slide is currently up if you're ready to start.
Yes, all right. So hi, my name is Sean Harbour. I'm a senior student at SUNY Plattsburgh, a double major in nutrition and fitness and wellness, concentrating in fitness management. So today I will be talking about how increases in mental toughness positively relate to increased distance covered in the 6-minute walk test for cardiac rehabilitation patients. Now, it's important to know that cardiovascular disease is the leading cause of cardiovascular events such as myocardial infarction and death in the United States. It has been for the past 10 plus years. So this is a significant issue. It affects millions of people every year. Those who experience cardiovascular events are referred to a phase 2 cardiac rehabilitation program to improve their health and quality of life. This is a secondary prevention to ensure that their current condition doesn't worsen. Now, the total distance covered in the 6-minute walk test is a strong predictor of cardiac rehabilitation outcomes. Also, mental toughness has been found to predict well-being. So this study today, it's innovative because it's new, it's never been investigated, and it's holistic in the fact that the 6-minute walk test is the physical part and the mental toughness is the psychological part, which fits well with the theme of this conference of psychophysiology. The study is investigating if mental toughness levels relate to changes in total distance covered in the 6-minute walk test during phase 2 programs. So how did we do this? There were 29 patients at the Baylor Scott and White Hospital in Texas who went through a 12-week cardiac rehabilitation protocol. And during this, mental toughness index scored mental toughness 4 times every 4 weeks. And the 6-minute walk test was measured in meters, captured twice when the patients were admitted into the hospital and discharged from the hospital. Now, the results showed that those who increased their mental toughness had an increase in distance of the 6-minute walk test by 263 meters compared to those whose mental toughness scores didn't increase. So they nearly doubled the distance, which is significant because, as I mentioned earlier, the total distance covered in the 6-minute walk test is a strong indicator of cardiac rehabilitation outcomes. So the further the distance shows the likelihood that the patient is healthier, has strong cardiac rehabilitation outcomes, especially in their cardiorespiratory fitness. So in other words, those who increased their mental toughness had more successful outcomes compared to those who didn't. Now, in terms of research design, this was an observational study, and the correlation found in this study provides enough evidence to go back to the hospital and investigate causation of mental toughness interventions that could possibly support and assist cardiac rehabilitation patients in increasing their scores for the 6-minute walk test. This is significant because if causation can be proved, then this is an additional solution that can help millions of people. Thank you for allowing me to join this innovative study. I am looking forward to your questions and feedback.
Okay, this is open for discussion. If you have questions, I'd ask you to come
Okay.
to the podium. Okay, I'm going to get started off with the first one. All right, so I'm really passionate about this group, because cardiac rehab is where I know a lot of my colleagues got started, and then I think it's one of like our most impactful interventions that we have as a profession. What's the next study going to look like? So we know mental toughness seems to be an important factor, but what is the next logical step in your mind?
So the next step would be doing an experiment with the observation. We would have 2 groups, so a control group and then the group doing the mental toughness intervention.
Okay. And is that intervention going to be over a period of, what do you think is a sufficiently long time for the mental toughness intervention? Is it the same duration as cardiac rehab itself?
Yes.
I have a similar question. You can just ask, what is the intervention? How do you increase mental toughness?
Yeah, so Adam has a question about what is the actual intervention? How do you increase mental toughness? What does a mental toughness intervention look like?
So there's a couple different ways. There are mental toughness coaches, but a strong way to increase your mental toughness is through positive self-talk, preparing yourself and focusing for the goal. It can help with increasing confidence and competence as well, and resilience, so that people feel confident in being able to accomplish.
Okay. Any other questions?
I'm just wondering how many people increased mental toughness and how many people didn't out of the 29?
Yeah, out of the 29, how many people increased their mental toughness and how many did not?
That's a good question. So if you look at the graph, the larger blue bar in the middle is the median with the outliers. So most of the patients did increase their mental toughness.
Okay. Does anybody have any other questions? All right, thank you very much for your presentation. That was great. The President's Cup is actually a national competition that is held by the ACSM, and each individual regional chapter has their own President's Cup, and the winner from each chapter goes to represent their conference or represent their chapter at the national conference. I want to say that I'm very grateful for all the students that came in person and participated virtually. To participate this year, we had a great turnout. All the abstracts and presentations were great. So I'd like for everybody that presented an abstract to stand up so we can give you a quick round of applause. So stand up if you presented today. So research is not, you guys can sit down, take a break. Research is not something that maybe a lot of you were familiar with before you started, but obviously now you kind of know what goes into it. And we're all here in part because of research. We're all here to find out answers, right? And research is one of the ways that we can do that. And we apply the scientific method to get to those answers. So we hope that you had a good experience, that you consider our chapter your research home in the future. So without any further ado, I'd like to announce the winner of this year's President's Cup. The winner this year is Nick Dvorak for his presentation, Shoulder Arthroscopy with versus without subscapular nerve release, clinical translational for elite bone athletes. So thank you so much. We'll be in touch about the arrangements for your participation in the national conference. So let's give Nick a round of applause.